All right, let's just jump straight into a pretty uncomfortable reality in today's explainer. Every single medical school out there basically operates with two completely separate curricula. One is, written down, approved by committees, perfectly quality assured. But the other one, it's totally invisible, it's unaccountable, and according to decades of research, it is actually way more powerful in shaping who doctors eventually become. So today, we're breaking down a highly provocative but completely factually accurate concept, the hidden curriculum. I want you to think back for a second to your own professional training, or maybe just picture a doctor you've seen recently. Think about how they handle uncertainty. Think about the exact tone of voice they use with patients, or how they interact with the nursing staff. Now ask yourself, where did those values actually come from? Like, were they explicitly listed in some syllabus? Were they tested on a multiple choice exam? Or did they actually come from watching older doctors when nobody important was looking? This brings us to a concept first coined by educational sociologist Philip Jackson back in the 1960s and then famously applied to medical culture by Frederick Cafferty in 1998. It proves a slightly terrifying point. Those unplanned, totally unscripted clinical interactions shape a doctor's true identity way more than any textbook ever could. As the saying goes, the official curriculum tells students what medicine is, but the hidden curriculum shows them what medicine actually does.
Which leads us to Section 1, the invisible medical syllabus. Let's look at the unspoken rules building a doctor's true education.
So there is this massive, stark dissonance in medical education. On the one hand, you've got the formal curriculum, right? The pristine, quality-assured facade filled with learning outcomes, OSCEs, and those inspiring lectures. But lurking right underneath that is the hidden curriculum, the raw, gritty, unscripted reality. We're talking about the senior consultant who dismissively waves away a patient's pain. It's the dark, cynical joke shared in the doctor's break room. It's the resident staying 3 hours late without being asked just to prove they're tough. These unspoken moments, they aren't on any syllabus, but they are absolutely what molds clinical behavior.
Moving to Section 2, where the curriculum hides, we really need to pinpoint exactly where this invisible syllabus operates on a daily basis.
And spoiler alert, it thrives in the unscripted zones. It's hiding in the chaotic morning ward rounds and the hurried clinical handovers at the end of a brutal shift. It's in the exact tone a senior doctor uses when a junior nervously asks a question. And it is crystal clear in how the most vulnerable patients are spoken about when the door is closed. Students are kind of like fish swimming in water. The fish don't notice the water, they just swim in it. Medical students don't consciously notice this hidden curriculum. They simply absorb these institutional messages from highly pressurized environments until they actually adopt them as their own personal values. Now, the research here is totally fascinating. It shows that students are exquisitely sensitive to the gap between what they're formally taught and what they actually observe. When the official values match what they see on the ward, their professional identity is strongly reinforced. But when they conflict, say a morning lecture preaches that patient dignity is paramount, but that exact same afternoon, a patient is left exposed and treated poorly in a busy corridor, students learn a really cynical lesson. The formal syllabus is just a fairy tale strictly for passing exams, and the real rules of survival are what they see and practice. All right, Section 3, the toxic toll on doctors. Let's look at the deeply provocative, factual impact this has on a clinician's psychological well-being. Researchers at Harvard Medical School mapped out exactly how students process these glaring contradictions. And as it turns out, they're basically forced down one of three very uncomfortable paths. First, they might rigidly try to stick to their original idealistic values, which almost always leads to immense, burning moral distress. Second, they might just adopt the bad behavior they're seeing, sort of rationalizing it to themselves as realistic professionalism. Or third, they just break down. They become completely cynical, disengage from professional values entirely, and start viewing medicine as just a stressful, technical job rather than a moral calling. So the grim reality here is that when we encounter those deeply cynical, burned-out doctors, it is rarely just an individual character flaw. What we're actually looking at is a massive, systemic educational failure, fueled directly by this unspoken culture that just eats away at their empathy year after year. Which brings us to Section 4, the patient safety crisis. We have to elevate this from an educational issue to a literal life-or-death scenario to really see the impact. Because the truth is, the hidden curriculum doesn't just shape who doctors are inside their own heads, it shapes what actually happens to patients on the operating table. Think about it. Prioritizing institutional hierarchy and saving face over speaking up about a mistake, that's not just a personality quirk. It is exactly what these doctors were systematically trained to do by their environment. When you investigate major, well-documented safety disasters,
you consistently find these exact same hidden drivers. Take the tragic Libby Zion case in the US. A young woman died because exhausted juniors managing a complex drug interaction were implicitly taught that concealing their uncertainty and definitely not waking a sleeping attending physician mattered way more than asking for help. Or look at the Bristol heart surgery scandal in the UK. Junior staff watched horrifically unsafe pediatric surgeries happen, yet they stayed completely silent. Why? Because the unwritten rules of their environment explicitly taught them that challenging institutional hierarchy was professional suicide. But listen, there is a way to solve this. Welcome to Section 5, the power of positive modeling. Let's talk about how this exact same invisible force can actually be weaponized for good. Think about the sheer power of an unhurried, compassionate conversation with a terrified patient. Think about a senior surgeon demonstrating true intellectual honesty by just admitting a mistake in front of their entire team. Think about treating every single hospital staff member, right down to the healthcare assistants, with immense respect. Studies by Kenny and colleagues show that students actively seek out and copy supervisors who display these exact traits. The doctors who shape students the most aren't the ones giving the fanciest, most articulate lectures. They're the ones whose daily, unscripted behavior students desperately want to emulate. And that brings us to a massively empowering realization. If you teach, if you lead, or if you simply practice medicine in front of literally anyone else, you are writing the hidden curriculum in real time. Every single time you acknowledge a gap in your knowledge or treat a junior colleague with genuine dignity on a terrible shift, you are purposefully engineering the exact environment that creates incredible, safe doctors. Let's move to Section 6, Illuminating the Dark. We're going to break down exactly how both learners and teachers can strip the danger away from this invisible force. You know, we can't completely eliminate the hidden curriculum, but we absolutely can illuminate it. If you're a learner, your defense basically comes down to a few core actions. First, name the gap. When you spot a discrepancy between what you were taught is right and what's actually happening on the ward, call it out in your own head. Second, use structured reflective practice. By actually examining what the environment just tried to teach you about hierarchy or patient care, you build a psychological shield. This act of reflection stops you from unconsciously absorbing toxic lessons that, let's be honest, you'd instantly reject if a professor actually wrote them on a whiteboard. Now, if you are a teacher or senior staff, your most effective intervention is simply making your internal reasoning visible. Don't just show juniors what you do. Explain exactly why you're making a specific choice. Narrate your thought process. Tell them how you're personally dealing with clinical uncertainty in a tough case. And deliberately give explicit feedback. Praise the people who have the guts to speak up when something seems wrong. You are intentionally turning dangerous, silent assumptions into explicit, positive teaching moments. As we wrap up this explainer today, I want you to really reflect on your own clinical origins. What did your training teach you that nobody ever actually intended? What habits, what fears or biases did you pick up that were definitely not on any official syllabus? Take a hard look at the moments you are creating right now in your own daily practice. Consider how you can deliberately illuminate those dark spaces for the next generation of professionals, because they are watching your every single move, learning how to be a doctor simply by watching you be one. Because whether you realize it or not, you are actively writing the hidden curriculum every single day. So ask yourself, what exactly are you teaching? Thanks for joining me for this explainer, and I really hope it leaves you looking at your daily interactions in a totally new light.